So thank you very much, Tom, for taking the time and joining us. Even even virtually. Originally, this was not planned to be in person, but given what's happening, we are thankful to have you from your place. And Tom, for those that they don't know, is an associate professor of health services, policy and practice at Brown University, and the director of the Center for Evidence Synthesis in Health. So he comes from the same land that I come, and he studied medicine in Greece. And I guess since straight from Greece, I guess, to Brown, or actually not sure what the steps were in between, but landed eventually in Brown, and lots of work in evidence synthesis, in modeling, in all kinds of places, in a very, very prolific career so far. So we're happy to have you, and we're happy to have you overall in our kind of surrounding. So thank you again, and take it away. And do you want us to wait for questions and hold them for the end? How would you prefer?
However you wish. I think that I can work with both formats. And actually what I would like to, so thank you very much first for the gracious introduction. This was a shift from the things that we were planning to discuss initially. I was going to talk about different things like, sequential designs for learning emulators of computationally expensive models and this kind of stuff. But the world that we are facing now has made us drift to other places. So thank you very much for the invitation. It's a good opportunity to virtually get out of home in any fashion. Do interrupt me as I go on. What I would like to do is I would like to discuss what we do locally in Rhode Island for the modeling of the COVID-19 epidemic, and actually get some feedback, because the thing is that we have been rushed into this without any preparation and without necessarily being infectious disease experts, none of us on our team. So the things that I will discuss are relatively traveling in many levels of specificity and abstraction, and I will apologize preliminarily about that. But I think that I will do my best to have some continuity. I would like to talk to you about the local modeling that we do in Rhode Island. This is joint work with Nikos Trikakis at MIT, another Greek, Jonah Pop, Sean Forbes, and John Fulton at Brown, and Maria Messick from the governor's office, and Bill McQuaid at the Rhode Island Department of Health. And I will jump directly into the problem. The idea is that we are facing this epidemic, and there have been a series of aggressive government measures that have been implemented, and there have been changes in people's behavior because we see what is going on in other places that are ahead of us in the epidemic, and we learn from the news how to deal with the epidemic in our interpersonal contacts. And all these things, the government measures and the changes in our behavior, have helped curb the epidemic, but it has been curbed at a very large societal and economic cost. Now, I'm a bit gracious when I say that we have curbed the epidemic, not that we are out of the woods, but at least we are, as you will see soon in Rhode Island, we have been on the downward trend. So the whole idea now is, how do we think about a progressive relaxation of the measures that the government has taken, so that we can kickstart the economy, but we do that in a way that minimizes, in some sense, the risk of resurgence of the epidemic. And this is a very difficult topic, and it's a topic, it's a question that has a lot of things hanging on it, many lives and many people's well-being, and therefore we we are very, very anxious when we are dealing with this topic. Let me start by giving you a few background data about where we are now in Rhode Island. It's the smallest state in the US. For those of you who don't live in the US, it's got only 1 million people. And this is a schematic that shows how the various data points have evolved. The accumulation, the current hospitalizations, this is the census of the hospitalizations for COVID-19 is shown in this blue histogram, and the red is the cumulative deaths. So today, or as of 4 days ago, these are probably our most recent data or 2 days old data. We had approximately 800 people who have been claimed by COVID, and currently we have roughly 150 people in the hospital, only 25 people in the ICU. Now, we don't know yet how prevalent the epidemic is in Rhode Island, because our seroprevalence studies, which have been conducted already, are still being analyzed and they have not come through. But the modeling estimates, and I'm gonna show you how we approached that modeling, estimate an attack rate of approximately 5%. So for those of you who want a refresher on what the attack rate is, perhaps you can think about it as 5% of the people have been moved out of the susceptible population. Therefore 95% of the people are still susceptible. So very much we are a state that is fully susceptible to COVID. As you can see here, in terms of dates, we started seeing some cases in the beginning of March. We know that the first confirmed or suspicious cases, let's say, came in the 27th of February. We probably had more before that, but there was a school trip that came back from Italy at that point. And then cases started resulting in increasing numbers of hospitalizations. We were going upwards in April, in March and April. The increase is, not exponential as you would have in an undampened epidemic. The numbers should go exponentially up very fast, but there's a progressive dampening of the epidemic that has yielded a sub-exponential growth and then a starting of a decline. So if you just look at the hospitalizations, you will see that the peak roughly was in the end of April, beginning of May. And since May, we have been on a let's say, steady descent. Rhode Island is the state that has the highest per capita testing rate. So we have a lot of data in terms of testing results, and I will show you how we're using these. But just to give you an idea, we have done 182,000 tests till today, and roughly 16,000 of these are positive. So you can see the cumulative number of positive tests, how it has evolved, overlaid on the number of hospitalizations and the number of new positive labs. And you could see that the number of new positive labs you could use to somehow track the hospitalizations. This, however, is a piece of data, the current testing, that is difficult to use, because we have been testing mainly symptomatic people and people who have been the contacts of cases, confirmed cases, and therefore, and in addition, in the beginning we had a scarcity of tests, so we were testing only the very highly triaged cases. Now we have an abundance of tests, so we can test many more cases. So the number of people, the proportion of people who have been tested, or the proportion of people with COVID who are among the people who have been tested, has changed over time. We are waiting for 3 seroprevalence estimations that are currently analyzed. This will tell us how the population looked like in terms of people who have gone through COVID in the around May. This is the dates where these data that these data inform about. And of course, we want these types of data because they can correct the model's drift, as I will say later. And Now, in terms of testing, we have started doing regular PCR monitoring of high contact groups, which I will call sentinel groups. And this regular testing, the hope is that it would help us keep tabs on the epidemic and understand where we're going. So I speak with a royal we because my colleagues and I at Brown and MIT work directly with the Rhode Island Department of Health. Rhode Island is a very, very small state. They don't have a Department of Health that has extensive expertise. So they are very, very willing and very, very open, and they have been exceptionally open in all the interactions. So all the analysis that you see here, they are being daily discussed with the chief of staff of the governor, and the governor sees a regular update, daily update of these types of analysis every day. So they are actually informing decision-making that is going on. So we have a real situation where we actually know that what we're doing is being heard. So I'm going to show you what we have been doing thus far. And I will tell you that I'm pretty worried about several of the things that have been done, that we have been doing in the sense that they are ad hoc solutions to difficult problems. So if I wanted to abstract the decision-making problem that I am going to talk about, we have a wider class of decision-making problems that have to do with long-term planning, etc. But today I would like to abstract a narrow decision-making problem, and that would be how do we decide how to move forward or move back in terms of relaxing measures, government measures. So the governor faces three choices: to either move ahead, and by that I mean proceed with a further relaxation of policies, whether or stay where we are, perpetuate the status quo, or perhaps regress. That would be unfortunate because it would undermine public trust if we had to go back, but it may be necessary if the epidemic gets out of control. So this is the decisions that we would like to inform in some fashion, and that's the task. So what is the general idea? Well, the general idea is that we would really evaluate moving to a next phase after we've had at least 4 weeks in a particular phase, and this is because there are time delays there's a delay in the time that any action that we do will propagate through the system of the epidemic, and we would want to learn some models that would essentially infer the status and the trajectory of the epidemic, and then we would summarize some of the model's results in terms of triggers that would be indicators of whether we should move ahead or stay put or go back in terms of tightening measures. And these triggers are set in a way that encompasses the decision makers here. It is the governor's attitudes towards risk and ambiguity. I use the terms risk and ambiguity in their formal sense. Risk in the sense of, you know, the uncertainty, the aleatory uncertainty that comes from the fact that we have small numbers and finite measurements and finite samples. And ambiguity is a more general sense of uncertainty that comes from the fact that we don't know what is the correct state of the world, what is the correct model for the epidemic, and we somehow have to work through ambiguity as well. So we are going to learn models that will help us do those things, learn those triggers, and then would also ideally help us allocate PCR testing budgets in terms of testing sentinel groups. In some abstract sense, what I'm describing is a control loop. There's the epidemics system. That is a system whose state is unknown, but we try to estimate it with our models. The models infer the system's status by sensing its status through the estimation of the triggers. And these triggers would inform our adjustments of measures, which would be the next input to the system, etc. I already said that this system is, this feedback loop has built-in delays, because whatever we do today will propagate in the system of the epidemic over a matter of several days, a couple of weeks perhaps, and then whatever system changes exist will manifest in the triggers, which are data that I will talk about, which are informed by data that I will show here after a few days. So we have a delay. And whenever you have delayed feedback loops, you have a risk of oscillations. For example, if you act too fast based on a delayed signal, you may overreact, and then you may have to overcorrect in the other direction, and so on. So our goal is to have an over-dampened control loop so that we will avoid any oscillations, and the oscillations would mean that we would have to regress to previous policies. The information that we have and how we learn models is by using data on hospitalizations, deaths, tests, et cetera. And we've had different time series over time and data problems over time. But increasingly from now on, we will have regular PCR monitoring of sentinel groups. So these are going to be selected sentinel groups for whom we would be doing cyclical testing to see if there's an uptick in the infections. And that would help us estimate the maximum shift rate of the system. And occasionally, perhaps every 3 months or so, something to be actually optimized, we will have seroprevalence surveys to correct for the drift in the system, to correct for where we are now in the population in terms of the attack rate. So this is a very high level description. And as I said, we want to learn various models that would try to infer the status of the system and the trajectory of the system. And the problem is that we have, we are modeling a system that is not a physical system. It's not governed by laws of nature, and therefore there's limited predictive ability. And this is a well-known problem. When you're trying to forecast the arrival of a hurricane, the hurricane will come no matter what you do. But if you forecast that we will have a catastrophic event in terms of COVID infections, people will react to that as they should, and the event will not realize. So it is a system, a man-made system that essentially is very volatile and reflexive, in the sense that the status of the system will depend on measurements and predictions about the system that we will do and we will announce to the population. So this means that when we do forecasts, and we want to do forecasts, primarily short-term forecasts here, we have to control how we do those forecasts. And any forecast is assuming that things will proceed similar to what we have seen in the past, but we have to have some control over how we do this forecasting. So in practice, trying to think through this, we decided to actually come up with with model variants that would react to more recent data or to all the data in different ways. So to give you an example, and I will make that more concrete with mathematics later, a very vivid memory was around April 15. So around April 15, which is what I plot here, the stuff that we had seen is a continuous rise in the hospitalizations, and we were making predictions for the future. And if you are here, the models may have already started learning that, this thing does not go up exponentially, so there must be some dampening going on. But how much do you trust the recent data versus all the data in trying to predict what will happen in the next 15, 30 days? And you can imagine that analogous things you would have right on top of the peak, which is around, April 30 or May 1st. Depending on so you could have a range of models that have a different inertia in terms of looking at the recent data. So the more inertial models make forecasts that assume stable time trends throughout the process of the epidemic, and this means that they may miss recent trends. For example, no one could predict that well, I don't know if I couldn't predict that we would have all these protests going on. And all these protests with people going out and mingling is an opportunity, of course, for the epidemic to resurge. So if we see any uptick now in a week, should we consider that as a fluke, or should we consider it as something important? And models that are more inertial would be tending to consider a little uptick as a fluke, because they consider that the same time trends that we have seen till now would persist, whereas less inertial models may actually allow the more recent data to move the prediction much more. So they're like, you know, a windsock that flops in the wind, and they can produce forecasts that are more similar to the most recent time trends. Therefore, they are overfit to recent data. They may detect resurgences earlier, but they're much more noisy. So we fit 14 model variants that have really their big difference is how inertial they are. They are somewhere on this continuum. So what I would like to do is I would like to first describe the models, their common parts, and then I will talk about how we do this different modeling in the time trends, and then I will show you some indicative results and show you how we do the triggers. I'm going to move fast because I have already spoken too much. The models have an abstract structure that is really a 5-compartmental model. Most of you probably are more familiar with these types of models than I am, but the idea is that there is an infectious process, so people are partitioned into susceptibles who have not yet been exposed to the disease. There's an infection process that moves susceptibles to exposed. They become exposed to the virus by coming into contact with people who are into the infectious categories of the population. And therefore, this infectious process moves people from the susceptible to the exposed. The exposed are people who are pre-symptomatic and they do not have ability to pass the virus. They're non-contagious, but then they become pre-symptomatic and contagious, and then they become optionally symptomatic. So a fraction of the infectives are symptomatic and they are contagious, and in the end they are removed. Some of them die, some of them live. And the system, the way that we have built it, is a fully Bayesian system where all these transition probabilities, etc., have distributions on them, and you can see the mean times for the distributions ranges, if you will, for the various transitions. Typically, these models are described with differential equations. So this is the dynamics of the system. I'm just going to walk you through some parts of the dynamics. For example, let's see a simple state like the infectious. The rate of the change in the proportion of the people who are infective depends on how many people come in, how many people go out. How many people come in is how many were in the previous state times a coefficient that is dependent, that is dependent on the mean time to transit from the previous state to this one. How many people go out, it depends on how many you have already in that state, times a coefficient that depends on the mean time to move to the next state, and so on. The system starts from an initial condition that has to be defined, and largely from the initial condition onwards, it is assumed to be a closed system. Let's focus a bit on this first equation that describes the dynamics, the infectious process, because all the game is here. And the idea is that the rate at which the susceptibles are becoming exposed depends on how many susceptibles you have and what fraction of the early infectives and the infectives are available to infect susceptibles. And I will explain this. And the force of the epidemic depends on a time varying coefficient A. So this A coefficient is modeled as a maximum infection force of the infection times time-dependent dampening effect. So this B of t function is a function that lives between 0 and 1, and essentially encodes how much dampening occurs on the epidemic. And this dampening is due to the net effect of, you know, whatever changes people's behavior has seen, because we see stuff, we learn how to act, whatever governmental measures have been implemented, perhaps that have had an effect, like closing of schools or closing of big events or stay-at-home orders, and perhaps even natural changes if temperature and humidity end up doing anything. So this dampening function is critical, because without that dampening function, the whole system goes on exponentially almost in the beginning, and then rushing through the various states. And because we are not seeing an exponential growth, what we see is a dampened growth. Comparing the dampened growth with the anticipated exponential growth, the model can infer this B of t function. So it can infer what is the dampening effect that we are essentially seeing on the epidemic. And the 14 model variants that I talked about that essentially, you know, rely more or less on the most recent data essentially differ in the way that we specify this dampening function. Let me just get out of the way what happens with the people in infectious states who are available to infect people in the susceptible state. I'm gonna, this is a remnant of earlier stages in the model, but it has persisted. So essentially, I'm gonna talk about the early infectives. So the early infectives, all of them are pre-symptomatic. So the ones who are available to infect people who are susceptible are whoever is not isolated. So whoever is isolated is people who have been identified perhaps through contact tracing efforts of the Department of Health. And similarly, the symptomatic fraction of the infectives, some of them are isolated, and whoever are not isolated are available to infect others, and so on. So essentially, a fraction of the infectious states is available to infect the people who are in the susceptible state. So these dynamics are problematic. So essentially what we do is we want to solve these dynamics. We want to get a function P of t, where P is this vector that has the proportions of people who are in each one of the compartments over time. And what we know is the rates, and we know we can perhaps estimate an initial condition. And based on that, we want to solve these dynamics. Now, this system is annoying because it's, first of all, it's nonlinear. This A of t function changes over time. So it's a time inhomogeneous system. The second thing that is annoying is that it's not a linear system of differential equations. We have a product of states here. So in order to actually fit data to the system, we actually need the solutions to the dynamic system in order to put these solutions as parameters into data likelihoods. And so we are approximating the dynamics in a very normative way, in a very typical way. It's essentially a discrete time approximation of the system that is time inhomogeneous with a time homogeneous system. So the first thing that we do is we take the time and we partition it in time intervals in which this A of t function is constant. And roughly think about it as, like, 1 day is one time interval. So we re-estimate this system every day. And for the mth day, the mth time interval, you can rewrite the dynamics like that. There are the B of t function now is going to be a constant that it's buried into these parameters, that alpha sub E sub m. This is for the early infectives, apart for the early infectives in the mth time interval, for the infectives in the mth time interval. And essentially it's a vector of derivatives times a linear scaling matrix times the vector of the states that we want to solve. But this is a linear system. These linear systems have known solutions. They're exponential type of solutions. It's a hyperposition, a hyperthesis of exponential solutions. And the solution in the mth time interval has this form. And The form is that at any time t in this mth time interval, if you start from the beginning, the state at the beginning of that interval, you just multiply with a matrix exponential function according to this formula. But the beginning of this time interval was the end state of the previous interval. And if you go like that recursively, you can write a formula. Strictly speaking, this formula is not correct, but you can write a formula that essentially you can use to estimate the proportion of the vector of those proportions as a function of the B of t functions that have been discretized now and as a function of the starting condition. Now, when you write the system like that, you can also estimate, you can also derive the formula for the RT, not the R0 at the beginning of the epidemic, but the reproductive number at any time point, at any interval, and that would be equal to this quantity. So I'm not going to talk a lot about modeling the initial condition, but the key idea is that no one knows how to start. This P of 0, the 0 is an arbitrary point in time, and we don't know what happens there. And what we do is we have a scheme to let the data fit appropriate values for the starting condition. There's a second option that I will not describe. So what sort of data do we have? We have time series of cumulative deaths. We have number of hospitalizations, people who are currently in the hospital, and we have number of cumulative hospitalizations, and we also have number of positive tests. So the people who die, we take them as a fraction of the people who are in the removed state at every point. So it's, it works out that you can do the integration. It works out to be the probability of dying times being in that removed state. The people who are hospitalized end up being the probability of being hospitalized times the people who are in the infectious state. People who are cumulatively, the cumulative number of hospitalizations is whoever passed through the hospital system and is currently in the hospital system or is removed. So there's a question that says, did you model death rates specific to each SEIR compartment? No, so there are no, so this is a very simplified version. Let me move back. The only death happens in the removed compartment, and we don't model people dying from other causes throughout. And of course, it's an oversimplification. When it comes to the number of positive tests, this is a bit tricky because, as I said, tests were scarce in the beginning and then they became more available. And the way that we target tests is evolving over time, probably slowly evolving over time, but it is at best proportional to the number of infectives or the proportion of infectives in the population. So there's an unknown proportionality constant that we hope that it is a slow change in constant, and we model it as a slow moving function of time. And if you start doing this type of thing, you can and under some assumptions about the test's performance, mainly that the specificity is high enough, you can show that the rate of change in the probability of the positive tests locally over a short time period would be equal to or approximately equal to the rate of change in the infectives. And this is how we use this information in the model. The actual implementation is a bit tricky, but this is how it's done. Now, to fit data to this type of model, the stuff that I talked about is like the way that the structure of the model is. And what we do is we regress data on the structure. It's essentially a nonlinear regression that we are doing. And the observations that we have are partial observations. We don't observe numbers in each one of the compartments, but we, depending on what data we observe numbers on collapsed summations or fractions of summations of the compartments. So take a look at this example that shows one data pattern For example, we have the number of people who are hospitalized currently, the number of people who have been discharged, the number of people who have been discharged, and all the rest. So at any given time point, we can model this as a multinomial distribution conditional on the true proportions of the population, conditional in the true proportions in the population, and the correspondence in the true proportion of the populations happens with this design matrix. So we really need to correspond the probability, for example, of being currently hospitalized to the probability of being currently hospitalized here, which is probability of being hospitalized times however many we have in the infectious compartment. We need to correspond it to the number of people who are currently hospitalized in this multinomial distribution. So we have a design matrix D2 in this particular case that looks like this. And if you do the matrix multiplication, you will see that if I multiply this design matrix with the vector P of T, what I get here is the probability of being in all the rest categories. Here I would get the probability of being hospitalized and infectious, and here the probability of being hospitalized and recovered, so therefore being discharged from the hospital. So by putting together such design matrices, we can accommodate arbitrary data patterns. And one of the challenges that appears is that we have, and this was very prevalent in the beginning, we had overlapping data patterns in the sense that, for example, we knew the number of currently hospitalized, the cumulative number of the discharged, which includes people who died in the hospital and are discharged, and the cumulative number of the dead, which includes people who died in the hospital and out of the hospital. So these two latter things, the cumulative number of hospitalized and cumulative number discharged and the cumulative number of the dead, they have a common proportion, the people who died in the hospital, but we did not know that number early on. Yet we want to use this data. So you could ignore a piece of the data. You could try to break it into mutually exclusive counts, but we didn't have that thing early on. Or you can model these pieces of data using a time offset trick that we invented for this thing, where essentially each one of the available observations, which may be partially overlapping, conditional on the proportions in the population, is going to be modeled by an independent multinomial. So what we pretend is that one of the overlapping data patterns is not observed on day t, but it is observed on day t minus a small epsilon, perhaps 5 in 1,000 days. And the other overlapping data pattern is observed at day t plus a small epsilon. And essentially these two vectors are now correlated through the structural relationship of the underlying probabilities. So these are the common ways that the models are being built, and there are now a series of alternative variations in the specification of the dampening function that defines whether we are in a more inertial model or in a less inertial model, a windsock model. So a model that fits the data well or not. So let me fly through this. In general, the dampening functions are modeled as they live between 0 and 1, and they have a temporal component and a covariates component. So there is a link function that could be any sigmoid. We've tried many sigmoids. Logit works as any other. That sigmoid that ensures that the B is going to live between 0 and 1. So we can, for now, forget about this H function. The covariates could be no covariates at all, or it could be various covariates like Google mobility data. So we have various mobility data from cell phones that Google has made available to everyone, and we can use them as proxy of humans' mobility and perhaps behavior, and perhaps we can learn some explanatory variables about the dampening function by using the Google mobility data. We have also done in the past government measures, but we have moved away from that for various reasons, and we have not done temperature and humidity in any serious effect. So you could have no covariates or some covariates, and when you have covariates, these are disease, are time-varying covariates, and there's a beta coefficient vector, and this beta coefficient vector, it may have a lasso penalty on it, or it may be unconstrained. So this is a set of models that you can build by varying these choices, and then for whatever is not explained by the covariates, you may have a residual temporal effect that would essentially say how the B of t function changes over time. And essentially, over time, people learned how to deal with the epidemic, and the dampening effect, no matter what you try to explore and explain with various explanatory variables, the dampening effect may be a residual function of time. So, you know, in terms of residual temporal effects, we have no effects, or we may have just a linear function that assumes that people's behavior is such that they learn how to adapt constantly over time, and this is going to have a linear form as a function of time with a translation. This minus xi moves the whole line left or right by xi days, and therefore moves the inflection point of the sigmoid h left or right, essentially giving flexibility in how to fit functions. Or we could actually have not a linear trend, but linear splines with 1 knot, 2 knots, or 3 knots. We have models with 1, 2, and 3 knots, with the knots being estimated by the data. And we have also started playing with models that have fixed knots every 7 days. And these latter models that have many knots essentially allow the last piece of the data, the times that are after the last knot, to vary depending on the most recent data. So essentially, these are the Windsock models that conform very well to, or better than other models to the general, to the latest data, whereas models that have just a linear function over the whole time trend are more inertial. So by taking combinations of these parameters, of these options, we have selected 14 model variants, and we run all these model variants every day. They are full Bayesian inference models, and we don't even run them long enough. So this whole thing has to be done on Amazon Cloud on supercomputers, and it takes, you know, roughly 3 hours for 2.5 hours now for the more recent models that have a lot of data to run. But we have 14 model results every day. So we have results from these models. How do we trigger decisions? Because this is what I was talking about. We essentially are going to talk about triggering decisions on whether to move ahead, go back, based on whether the estimates that we have about how many ICU beds we will need, or how many total beds we will need, or how many new hospitalizations, or what the current estimate for the RT is above or below a threshold with some certainty. So, for example, if our ICU beds are below 133, which is a fraction of our total surge capacity across all our hospitals, is below this number with 50% certainty, then it would be a trigger to move ahead. Analogously, or for when to go back if it's above a number, or otherwise it's a trigger, it's an indicator to stay where we are. So essentially, for the number of ICU beds at a particular time t, if this is the density and this is the lower bound and this is the upper bound, what we are doing is we are estimating 3 probabilities, 3 masses: the mass that is below the lower bound, the mass that is above the upper bound, and the remnant, P1, P2, and P3 equals 1 minus P1, P2. And based on that, we will make our decisions. So these three probabilities sum up to 1. And in order to visualize them, Sean was kind enough to come up with a scheme. And the scheme is the following. You know, these three probabilities, if you put them in a three-dimensional system, because they're constrained to sum up to 1, they live in this triangle. And therefore, in any given day, we can get an estimate on this triangle. So to visualize this, because this is just a flat surface, you can change the basis with a Gram-Schmidt orthogonalization and change of basis. And you can imagine that you look at this thing from the direction of the arrow, in which case you could be seeing like something like that. So the origin would be exactly at the center, and various proportions that sum up to 1 would live in this triangle. So this is a typical ternary representation. And essentially, you can just take a look at this graph, and you can use these graphs to encode what the triggers appear to show. So let me focus on the left-hand side, which is the trigger for the ICU beds. You remember that we said that we want to be 50% sure that the ICU beds are below a cutoff in order to move ahead. This would correspond to this green area. To move back, it would be the red area, and whatever remains is the yellow area. And what happens is, what I show you is predictions from the second of the three models that I have chosen to show you some predictions on April 15. So April 15, I showed it to you, was exactly that date where we were right before we see the curbing of the epidemic, but we had seen a lot of growth. And what does this show is that, you know, for the first day, we were well in the area that was safe, that was not triggering any alarms for the ICU beds. The next day we moved there. For the next day of predictions, we would be moving there, etc. So within 30 days of predictions, the second model was worried that we would actually see a situation where we would get into the red area. And you see that for the ICU beds, you see that for all beds, and you see that for the new hospitalizations, and also for the RT. And similar results we get, we can get daily for all the models, all the 14 models that we have. So let me show you some results with the three model variants so that you can appreciate the stuff that we have been seeing daily and the kinds of discussions we've had with people in Rhode Island. So this is these are results observed versus expected plots. The dots are the observed, the lines are the expected, and these are models that were fit on the 15th of April, so right at the end of that climb. At the end of April, which is just at the peak, and 15th of May, which is 15 days after the peak. And this is one of the models that is an inertial model, if you will. It is one that has a linear time component and Google mobility data, but the temporal trend is completely linear. There's no splines, there's no knots to make it conform to more recent data. So right at that point, the model was worried that you know, we will see a very large spike, and we would see a climb in the active cases, which are the light color, and a climb in the recovered cases, which is the dark color here. 15 days later, it was predicting that we will, and this is where we are right at the peak, it was predicting that we would actually start seeing a decline. Right after the peak, it was continuing seeing that decline, and these ups and downs that these curves have is because of the variability in the Google mobility data. This is a model that has mobility data in it that corresponds to some changes in the expected proportions. Here's another model that has three linear parts, so it's more flexible than the previous one, but its qualitative behavior is pretty similar. You know, apart from changes in the actual numbers, qualitatively it shows the same. But this is a windsock model, a model that has through 4 linear time parts. So it allows the more recent data to change the prediction quite a bit and focus on the difference between this model and the other two, the more inertial models. Take a look at what happens in the middle graphs, which is the April 30 graphs. You see that there is a little uptick here. Whoops, sorry. There's a little uptick in the cases that the more inert models kind of ignore, but the more sensitive model picks up and therefore signals, if you will, some sort of an alarm. So these 3 models, for example, were showing for the ICU surge. These plots are the number in the hospital, total number in the hospital, number expected in the ICU, actual numbers and predictions. The darker shades are 50% confidence intervals, 95% confidence intervals are the lighter shades. And you can see that initially, there was quite a bit of uncertainty, but a main estimate that we would see things spiking up. And then things change, as you see in the later plots. This is the high inertia model. This is the model that is more flexible, but doesn't have high inertia, but is not the fully flexible model. And you see that qualitatively, it has quite a bit of uncertainty that it will still, it could still go up. But this is the model that is the windshock model that could sound an alarm. And this windshock model shows that something is going on in this, even during the peak, that something might happen that we could be actually worsening, but it's not, the predictions are not such that would put us above our surge capacity in the next 30 days. So when you have 14 models that give you different predictions like these ones, you have to reconcile the outputs. So you have to go on and do some ensemble output integration. I'm not going to talk about it now. There's stuff that we are actively working on, and there are many technical difficulties, but there are 2 philosophies, and we are following both. Till now, we are following this robust-like philosophy that says, it's as if you do a robust optimization over each one of the models. You try to work with a model that has the worst case scenario or the kth worst case scenario, and guide decisions based on that. But another approach would be more Bayesian-like, and it would be like an online scheme where you learn adaptively the weights by which you would trust each model. So you can do a look ahead and various cross validations by looking ahead, 14 days, 15 days, 30 days, and see which models have been better than others, especially in the recent past. And based on that, you can adjust weights by which you would trust each model's predictions, and then use this weighted average prediction to make inference about the triggers. So these are 2 different philosophies. There's theory that explains how you could do this adaptive learning in an online setting, in the sense that you can get some guarantees that you would not be worse off, very much worse off than the best of these learners. So you're not going of these models, so that you're not, giving too much up. But there are complications, because usually these schemes have been done in the literature for models that give predictions that are yes, no, and univariate predictions. So we have to extend them to continuous predictions and to multivariate predictions. And so this is work that we are doing and will be doing over the summer, I believe. So at this point, we are kind of like looking at things qualitatively and using this robust-like approach. As I was alluding in the beginning, we are now starting doing explicit testing of sentinel groups. And those sentinel groups are high contact groups. So for example, they are first responders. people who work in the service industry, waiters, hairdressers, and so on. And we have a testing budget to go on and do targeted testing. And I see I'm almost out of time, so I will just talk about it very generally. Let's say that we have capital J of these groups. Then we want to do testing in such a way that it would allow us to detect an increase in the number of cases over T days, and these increase and interval are selected in such a way that we have enough time to react. For example, enough time to put in place our auxiliary system, our auxiliary hospital for putting COVID cases. And at the same time, we have a daily testing budget of K, and therefore you can find the minimum required sample size to over T days to detect a difference, and you can solve a mixed linear integer program that is specified here to see where to allocate the tests, in which way to allocate the tests. So what group is being tested with how many tests, and in what time schedule would you be testing the different groups. So I'm not going to go through this specification. I should have timed my exposition better. Apologies. Limitations. We have a very crude, quote unquote, model to model the system. There are some places where the models don't fit. So the cumulative hospitalizations are adrift that the model doesn't fit very well. So perhaps we could improve that by modeling in hospital transitions in a separate process, and or not so much modeling different age groups. There is another problem that is the really important problem, is that what we are modeling is an average process in the population, but most of our deaths and most of our important cases came from epidemics in nursing homes, and these are not following the same mixing as the general population. So we have to separate them out and model them with some statistical process, like a non-homogeneous Poisson process or a hoax process, like some self-excitatory process that would be a separate thing and then added on to the general population. We should be doing county level modeling. We have been doing very, very little in that because counties in Rhode Island are very small, some of them are, and we have problems with small numbers. There's a lot of underappreciated uncertainty. Our confidence bands are too narrow, and there's a lot of underappreciated ambiguity. We have very few functional forms, and perhaps we should augment our modeling architectures, perhaps using mean processes or even an agent-based model. And there's a problem also in communicating the technical aspects of the work and the risk and ambiguity that accompanies all the triggers to the decision makers and to the other scientists. We are extremely lucky that the governor's chief of staff who gets into our daily meetings is an MIT graduate. She's very, very quantitative, and she can follow all the discussions. She can program, she can do stuff here on her own, and she's the communicator. But you know, some people in the epidemiology department are not necessarily following all the details. So there is a breakdown in communication that we would have been facing much more intensely in another setting. That being said, I'm going to stop here. I realize now that I said too many things very, very fast. I hope something was of value.
Thank you, Tom. And it was definitely a lot of information, but really informative at the same time. And if people can stay, I think, and if you can stay, Tom, for another 15 minutes or so, maybe we can
for sure I will
continue the conversation. Thanks again. So if I'm going to start with questions from the group. If you have any questions, you can, I guess, post them on the Q&A. And maybe until I give them some time to write, I would like to ask you know, in Ontario, we are lucky and fortunate to have a centralized system of healthcare system, which allows us access to some of the fortunate ones, access to patient level data on hospitalizations, testing, and that became over quickly became quite more almost on, like not really real time, but maybe with a 3-4 day delay, 5-day delay. So would you have done things differently if you were, first of all, is there such a repository that you could have had access to? And if you were to have patient level data, would you have done things differently?
So we now increasingly have this type of data, individual patient data. In the beginning, we did not. The system is different in Rhode Island, in all other states. In the US, as you know, there is no centralized repository, but the hospitals very quickly were very open and they started sharing individual patient data. But through the various bureaucracies and because of, not the same data standards and so on, they had to be cleaned and harmonized, etc. So really we were plagued by data problems, but not as much as others. So in Massachusetts, for example, they don't have data from the hospitals real time. They don't have access to the individual patient data from the hospitals. To the extent that they don't actually have a model. The Department of Health does not use models to do projections, and they rely on models from academics. Had we had individual patient data, would we have done things differently? Perhaps, perhaps not. I have to say that when we first started, we really wanted very quick answers because we really were under time pressure to get, very big decisions about, how many hospital beds should we open if we see the same things that were happening in New York. We didn't see them, but this was a real possibility. So we had basic questions about whether to sink our resources into case management or close down the economy with social distancing, etc. And these were resolved by other models that are not discussed today, that were more deterministic type of models, and we used them to visualize things and explain to decision makers the limitations of various options. So because of the time pressure, I don't think that we would have started directly with patient level data. But today, we want patient level data to actually implement different approaches. So the typical way to do it would be with an agent-based process where we would deal with it as a statistical system. We would try to fit data in a statistical system, individual patient data in this statistical system, similar to what we do here with aggregate data. But you could use it to finely stratify, at a minimum, finely stratify the population so that you can, start talking about what happens in people who are older, younger, with comorbidities, without comorbidities, etc. So I suspect that we would have started in a similar way, but this is only because of the time pressure. I mean, I don't know how others, because I know that many of you have been involved in these kinds of efforts. I don't know how you have done it, but there was a very conscious choice to stay away from agent-based models. For example, in the beginning, because we could not parameterize them, and moreover, to do an exploration with a sensitivity analysis, we have to resort to our bag of tricks that use support points or various other optimizations, emulation, and this kind of stuff. And these things take time. So whatever you gain from computation time, you lose by implementing the solutions.
Yeah, I think I agree. The majority of the models that I've seen have been in a similar type, where agent-based modeling would be useful, especially for cases where you want to discuss, subgroups and categories of comorbidities or like subtypes that they would, you would want to act differently. But
or specific policies, right? I mean, a specific policy that says, keep 80% of people at home and leave only 20% who belong to some work sectors of the economy to move around. I mean, you cannot estimate those things without an agent-based model.
Yeah, I guess, and that fits to another question I had about spatial component, and you've touched upon it, and making decisions that they're. Oh wait, there's a. I'm looking at the Q&A, but there's a chat actually with questions. Is it?
There, I am.
Yeah.
I just opened the chat.
Orestes, Orestes, do you wanna unmute yourself, or Aida, can you unmute Orestes to ask the question? Or okay, he's gonna type it. In the meantime, sorry, it's first time.
Yeah.
Sorry. Lauren is asking, Lauren Cipriano, have you had outbreaks in long-term care homes? How are you managing outbreaks in high-risk groups in your model?
So we've had most of our events and deaths are from long-term care outbreaks, and this is a problem. As I was alluding to, this is a big problem because these people are not mixing in the general population. So this skews all the results. I fully expect the seroprevalence studies that come out. I fully expect them to estimate a prevalence less than 5%. Right now, the model thinks we are at 5% because we have all this. All these cases mixed into the general population. So in practice, the Department of Health acts extremely fast. Whenever there's a thing in a nursing home, they go down and they take ownership of it. They close it down, they implement protocols immediately. The problem is that when you have one case in a nursing home with symptoms, it's already out of and practically many people in the nursing home will have symptoms and they will become infected. So it's a main problem. So in terms of managing nursing homes going ahead, we have regular sentinel testing of nursing home staff weekly, and once testing of residents. So this means 20,000 tests per week. So this is not a small number. It's a huge investment, but it is a thing that seems to be important to do. Would it mandate changes in the structure of the model? Absolutely, absolutely.
So how do you identify, how do you define model performance in a situation where you have somewhat of an endogeneity problem? Like your model defines the action, and the action affects the quality of the performance of your model. Have you?
So I think that we have to be modest here. I mean, I think it's impossible to have a model that predicts the future in these kinds of situations, endogenous situations. I mean, what you can do is you can bracket plausible versions of the future so that you can then inform your decision making. And the way to, I mean, so in that respect, I don't know that you can really, that you can really evaluate those models. Their value would be in helping you avoid stuff that you might never see. Narrowly, you can examine the predictive ability of the model. So you could assess predictions because you have a time series. So you could assess predictions in a cross-validation scheme, but the cross-validation scheme cannot be the usual cross-validation scheme. It has to be one that works with time series. So you can have a cross-validation scheme that looks at an H horizon look ahead, right? So I have one model that I'm going to censor it on day 1, day 2, day 3, etc. And then I'm going to predict 1 day ahead into the future, 2 days ahead into the future, 4 days ahead into the future, and so on. And then I can create this, RMSE, or mean absolute error, or mean proportional error, or mean scaled error. There are various errors that I can put together to try to see empirically model performance. And this is metrics that one would use, if you will, to go here and adaptively learn weights for each model. So that's the best thing that I have as an answer, but it's a pervasive problem.
Yeah, thanks. So we have two more questions. I'm gonna do, Orestes asks, what is a good level of analysis? For example, in a large state like California, decisions are taken centrally by the governor, but there is heterogeneity in geography. So the R0 and ICU capacity might be very different in a town far from San Francisco or LA. How granular should the model inputs be?
Yeah, I mean, this is a central question, and I don't know what I'll leave aside perfunctory answers like, it depends on what you're trying to do, et cetera, and I'll go to the essence of it. In Rhode Island, we were lucky that Rhode Island is very small geographically, and it's like, it's compact. So we could get away with modeling state level data for quite some time. But in reality, if you have a state like California, it's illogical to model it with a model that thinks that everyone is freely and equally mixing with everyone else throughout the state, right? We know very well that on a macro level, when you average local compartmental models overall, when you average them, what you do is you average mini epidemics, and it tends to behave macroscopically, qualitatively in a similar fashion as each one of the individual epidemics, perhaps a bit flattened out. But this is not conducive to more detailed decision making or more detailed actions, because even if the government is giving decisions that pertain to the whole state, policies that pertain to the whole state, nevertheless, you may want to know what is going on in each one of the counties, because then you may want to focus your resources in one particular area, or you may selectively start reopening up the economy in some counties rather than others, as they did in Pennsylvania, I believe. So this is going to be a choice that essentially translates to a different modeling structure, to a different structural model, and therefore I would, if I had time, I would do things in many ways and put them in the ensemble of models, and then work with the ensemble as a measure for my structural uncertainty about what to do. More detailed, better, I think.
Cool. And then I have let's answer Farzana's question relatively in a short answer. Would you explain a bit your future work with patient level data?
Then what I would say very, very briefly is what we will do is move on to essentially what would look like an agent-based model where from the patient level data, one would try to learn the equations that govern the transitions. So this would look like a multi-state leveling problem in survival analysis. But I'm sure it's going to be extremely noisy, and I just don't know how it will evolve.
Awesome. Tom, thank you very, very much for taking the time. It has been really nice and very informative. Have a good
thank
time.
You.
And yeah, we're looking forward to see what's are you planning, can you publish? Like, do you have...
Yes. I mean, I'm on a lot of it. I have not shown you detailed data and or the internal documents because they're under a confidentiality agreement. But this thing at some point should be published, either a technical version of it or some contextual version of it.
Perfect. Okay.
We'll take it from there.
Thank you, Tom. Bye, everyone.
Be well. Thank you very much.
Bye-bye.